Thank you, my friend. Thank you again for inviting me to be sharing anatomy, to be with a student this time. I think that the people that are listening are people from medical students, okay, and a resident of cardiology. It is okay.
That's more or less your profile, yes.
Okay, yes,
And
it's
you are
just
also
to know the
biologist.
level of anatomy that we are going to see, and because it's also important to translate not only into electrophysiology, but also into imaging technique, for example, to echocardiography or CT scan. And what we are going to do is just to, vamos a pasar, is just to show a specimen, and also we are going to use the endocast, okay? Podemos quitar esto. The specimen is just to, the endocast is just to translate into the epicardial and endocardial morphological feature of the human heart. We are going to use during this time post-mortem specimens and the yes, I think that you need to do mute. Okay, can you hear me correctly?
Yes, we do.
Okay, then here you can see the specimen. This is a post-mortem human heart, and well, I am moving the heart in my hands, and what we need to understand, what is the attitudinal orientation of the cardiac chambers. For cardiology, for medical students, you need to understand what is anterior, what is posterior, what is superior, and what is inferior, because in this way you are going to be able to identify the different structures when you are doing echocardiography or you are moving different section of cardiac magnetic resonance imaging, or even when you are doing fluoroscopy, or now with the different navigation tools. Here in this specimen, what we are in, I am going to simulate an attitudinal orientation. My left hand is the diaphragm, and now this is the correct orientations, and you can see that this is the left atrium and this is the right atrium, and the only posterior chamber in our heart is the left atrium. And what we use usually as posterior view of the heart, this is not posterior, this is inferior or diaphragmatic view. And this is very important because we use usually the term groove of the heart, and this is the so-called posterior interventricular groove. This is the left atrium, this is the right atrium, and this is the left AV groove, and this is the right AV groove. And here you can see the interatrial groove. Therefore, this is the inferior aspect of the heart, and the inferior aspect of the heart is the base of the heart. Then, what we need to understand first is how is the orientation of the human heart in an attitudinal and correct anatomical view. Therefore, this is anterior, and this is the so-called sternocostal view. This is the sternocostal view, and this is the inferior view. And therefore, this is the sternocostal face. And this is the sternocostal surface. This is the left bordered, and this is the right bordered. And you can see that the apex belongs only to the left ventricle. This is the left ventricle, and this is the right ventricle. Here you can see the anterior interventricular groove, In the human specimen, you can see that this is 2/3 and 1/3. From an anterior view or sternocostal view, therefore, the right ventricle occupies 2/3 of the surface. And this is the left ventricle that is not only left, but also lateral and inferior. This is the left ventricle. Please note that this is the anterior interventricular groove. Let's go now to the left AV groove, and right AV groove. This is the right AV groove. Let's continue with the right AV groove, right, and here you can see the base of the heart. If you see in this blue mark, you can see that this is left and this is right. And this is the inferior or so-called posterior interventricular groove, and this is the interatrial groove. Then this is the cross of the heart. The cross of the heart, that this is the base of the heart. And note that the groove, the anterior, the inferior, the right, and the left AV groove, you can see the coronary artery and veins running through the grooves. Note that we use the term coronary AV groove. This is the left atrium, this is the left atrial appendage, this is the aorta, and this is the pulmonary artery. Let's go again to attitudinal orientations. Let's zoom and note in this specimen that the pulmonary artery is anterior to the aorta and the left atrium is posterior to the right atrium. This is the right superior pulmonary vein. This is the right inferior pulmonary vein, and in this case we are going to see this is the common ending for both left superior and left inferior pulmonary vein. This is the left atrium. And note that the more adjacent area for the right superior pulmonary vein, this is the superior vena cava. And this is the inferior vena cava. Let's go lateral to see what is the right atrial appendage. This is the right atrial appendage. We are going to see the difference between the right atrial appendage and the left atrial appendage because this is a finger-like appendage. And this is the base of the appendage, is all this area here. And note that this is the superior vena cava. This is the superior vena cava. And this is the inferior vena cava here. And all this area endocardially correspond to the so-called terminal crest. We are going to see this endocardially. Note that epicardially, you can see this area between the superior vena cava and the right atrial appendage. This is the terminal groove, and this is the area of the synod-nodal regions. You are going to see that the synod-nodal region is epicardially located when we compare with the endocardially located AV node or compact AV node. Therefore, let's see again the groove and the surface. Then, this is the sternocostal surface. This is the left and this is the right border. The left border is obtuse. Note all these morphology of the left border. Therefore, the name of these arteries arising from the circumflex artery are the obtuse marginal artery. You can see this artery surrounding the left AV groove, and this is the circumflex artery. Note that this is the main trunk. You can see that this is the aorta, this the left coronary cusp. You can see the anterior descending artery through the anterior interventricular groove, and here note that this is the circumflex artery, and all these arteries are the obtuse marginal artery, and note the circumflex artery surrounding the left AV groove. Well, with the left AV groove, with this artery, we can see this vein. This is a vein. This is the vein, and note that the origin of this vein and the vein running through the left AV groove here. Just a second. Note that this is the coronary sinus. We are going to see that the coronary sinus, the ending of the coronary sinus in the right atrium, this is the coronary sinus. Here, you can see this vein is a small vein. This is the Marshall vein, the coronary sinus running through the left AV groove, and the point where the Marshall vein arises from this coronary venous system, this is the great cardiac vein. The vein of Marshall mark the junction between the coronary sinus and the great cardiac vein. The great cardiac vein surrounding the left AV groove, and here you can see the anterior interventricular vein with the anterior descending artery. This is the anterior descending artery and the anterior interventricular vein. This is a well-known area for electrophysiologists that the name is the left ventricular submit. This is an area where some tachycardia, ventricular tachycardia, arise from this endocardially or intramyocardially, as we are going to see in some dissection. Please note that all these correspond to the pulmonary artery. This is the pulmonary artery, and this is the aorta. And note that this is crucial to understand the different orientations of the pulmonary artery and the aorta. This cross orientation between the pulmonary artery and the aorta is crucial to understand the attitudinal orientation from endocardial aspect of the right ventricle. And this is very crucial also for electrophysiologists to understand the QRS complex from VT or ventricular tachycardia arising from the so-called right and left ventricular outflow tract. Okay, let's go again from an epicardial point of view in this specimen. We comment that the first point we need to understand what is attitudinal orientation, what is anterior, what is posterior, what is left, what is right. This is the right border. Note that the right border is acute and the left border is obtuse. Obtuse versus acute. And here you can see the right coronary artery arising from the right coronary cusp, from the aortic root, and note this coronary artery and these branches through the right ventricle, and these branches and these branches, this is the acute bordet. Therefore, these coronary arteries are the acute marginal artery. Right AV groove, left AV groove, and you can see that all this area correspond to the right aortic appendage, left aortic appendage, and the appendage are over the left and the right AV groove. You see the appendage, and note epicardially that this is the superior vena cava. This is the right superior pulmonary vein. This is the left pulmonary vein, and this is superior, and this is posterior. Note all this area that correspond to the so-called transverse sinus of pericardium. The transverse sinus of pericardium containing this muscle from the right to the left atrium. This is the so-called Bachmann bundle. The Bachmann bundle is the more important interatrial connection between both atrium. Here, in this area, superior vena cava, right aortic appendage, this is the sinus nodal regions. Sinus nodal regions, connecting all this area through the most important interatrial connection through the Bachmann bundle between both right aortic appendage and left aortic appendage. Therefore, sternocostal view, anterior view, left bordet that correspond to the obtuse bordet, right bordet that correspond to the acute bordet, and left AV groove with the circumflex artery surrounding the left AV groove and the great cardiac vein, right AV groove with the right coronary artery surrounding the AV groove. Here we are going to have the tricuspid valve annulus, and here we are going to have the mitral valve annulus. Therefore, the circumflex artery surrounding the mitral valve annulus and the right coronary artery surrounding the tricuspid valve annulus. And here you see the inferior interventricular groove, the interatrial groove that is only one and is posterior, and the left AV groove. And we can see different components from the right and the left ventricle. We are going to see the inlet, the outlet, and the apical component for both the right and the left. But the apex belong only to the left ventricle. This is the left ventricle. And the apex belong only to the left ventricle. And this is crucial to understand, because we can use the term apical component of the right ventricular apex, but in fact, this is the apical component of the left ventricle. If we go to a drawing, you can see here a cross section. Let's try to see that this is the pulmonary valve, the aortic valve, the mitral valve, and the tricuspid valve. And here you can see that this is anterior and this is posterior or inferior. Then here we have the pulmonary valve and the aortic valve. And note that this is the origin of the, in this case, this is the mitral valve. Therefore, we have the circumflex artery, and in this case, we have the right coronary artery. And here, this is the right coronary artery, and this is the circumflex artery, and this is the anterior descending artery. And note that this is the mitral valve, this is the aortic leaflet of the mitral valve because it's anterior and close to the aorta, and this is the mural leaflet, that this is posterior. And here we are going to see that this is septal, this is anterior, and this is inferior or posterior. And this is the non-coronary sinus. Therefore, this is adjacent. In those cases that we have one coronary artery arising from this sinus, we need to use the term adjacent, because now, in this case, in the normal case, with this trivalve, the term is non-coronary. And from the pulmonary artery, this is anterior, this is left, and this is right. We can use right adjacent, left adjacent, or not adjacent valve from the pulmonary artery. This is the pulmonary artery, that you can see that the pulmonary artery is anterior and left. And in the center, we have the aorta. The aorta, the anatomic relation between the aorta and the pulmonary valve is important from an attitudinal orientation, because we are going to see that the septal leaflet is inferior in relation when we see the anatomic relation between the tricuspid valve and mitral valve. You can see that the tricuspid valve is inferior in relation with the mitral valve, resulting in the atrioventricular junctions. This is the right atrium and this is the left atrium. But in the case of the pulmonary artery is superior in relation with the aorta. Therefore, the tricuspid valve is inferior in relation with the mitral valve, but the pulmonary valve is superior in relation with the aortic valve. Then, let's continue with the venous coronary system. Here we have the origin of the coronary sinus, and here we have the coronary sinus, and the great cardiac vein, and the anterior descending here, and the anterior, this interventricular vein. This is all this area is the coronary sinus. The coronary sinus with its origin close to the septal leaflet of the tricuspid valve. Therefore, we have two leaflets for the mitral valve, anterior and aortic, posterior and mural. When we see these different, note that the aortic have this morphology and the mural have this morphology, different length and different attachment of both leaflets from the aortic and mural. And we have two papillary muscle and two commissures. Here you can see that this is anterior and lateral, and this is posterior and medial. And we have three papillary muscle from a tricuspid valve. This is the short axis. This is the left ventricular submit. This is the short axis. And it is very relevant to know this anatomy of the short axis. Now, let's go to this point. This is the so-called, we are going to see in the specimen, so-called mitro-aortic continuity. This is the mitro-aortic continuity between the right and the non-coronary cusp, between the right and non-coronary cusp. And here you can see this area and this area here, this and this. This is the left fibrous trigon, and this is the right fibrous trigon. This is crucial because can you see this artery? This is the AV nodal artery. This is the posterior descending artery, and here this vein is the middle cardiac vein. You can see this area of the base that you have the right coronary artery, the posterior descending artery, and the middle cardiac vein. This is the base of the heart. This is the so-called inferior paraseptal regions. This is the so-called inferior pyramidal space. This is crucial to understand all this area because this is out of the heart. This is the area that we are going now. You can see this in the specimen here. This is the vein. This is the vein. This is this vein. Imagine that this is in this position. This is the vein, this vein, and this is this one here. Therefore, this is the inferior interventricular vein, and this is the right coronary artery. This is the right coronary artery surrounding the mitral, in this case, the tricuspid valve. Here you can see the tricuspid valve, and this is the circumflex artery surrounding the area that corresponds to the mitral valve. And this is the great cardiac vein. This is the great cardiac vein, and this is the anterior interventricular vein, and this is the anterior descending artery, the anterior descending artery. Therefore, this area that you can see here is this area. This anatomic correlation is crucial to understand all this space that you can see here in yellow here, that this is the membranous septum. This is in yellow, this is the membranous septum. And what is the relevance of this blue area and yellow area? The right fibrous trigon and membranous septum. This is the so-called central fibrous body of the heart. And the central fibrous body of the heart, this is where the His bundle go through this fibrous tissue. The atrioventricular component and the interventricular component of the membranous septum, and the right fibrous trigon is the central fibrous body of the heart. And the central fibrous body of the heart is the His. It's crucial to understand where are the conduction system and the AV bundle. Therefore, please note all this area. Septal leaflet, orifice of the coronary sinus, membranous septum, And all this area is the area of the compact AV node and his bundle, the AV nodal artery. And this is the area that we are going to see in the specimen as the term triangle of Koch. The triangle of Koch with different limits between the septal leaflet and the central fibrous body of the heart. The central fibrous body of the heart is part of the fibrous skeleton of the heart. And here you can see the annulus of the tricuspid valve that is not completely surrounded by connective tissue with different thickness. The same with the annulus of the tricuspid valve, not always completely surrounding by the fibrous tissue. Sometimes it's thinner, even with some muscle here. And this is the mitral-aortic continuity here in green, in connection between the aortic leaflet of the mitral valve and the aorta. And this is very important because this mitral-aortic continuity is the difference between the right and the left ventricle. They are not there's no continuity between the pulmonary valve and between the aortic valve and the tricuspid valve. Therefore, the short axis, to understand the short axis is crucial. What is anterior? What is posterior? What is left? What is right? What is the AV groove surrounding the right AV groove by the right coronary artery, the AV nodal artery, and the posterior descending artery? What is the dominant coronary artery in this drawing? This is the right, because the posterior descending artery arrives from the right coronary artery. The term dominant coronary artery is also very important because the AV nodal artery and the posterior descending artery, that is in fact inferior descending artery, arises from the dominant coronary artery. In 30% of the specimen, the dominant coronary artery may be from the left side, from the circumflex artery. Sometimes we have both dominant coronary artery. We have the circumflex artery through this area. Therefore, please take into account this, this drawing. And now let's go to this specimen here. This is the different specimen, just as reminding of the epicardial aspect of the human heart. You can see the pulmonary artery, that this is anterior to the aorta, and you can see the aorta. Let's go in these positions. Here you can see the pulmonary artery and the aorta. This is the left atrium, and this is the right atrium, left and right. And note the pulmonary artery, and here in this space you can see the transverse sinus of pericardium. When you analyze this transverse sinus of pericardium from an epicardial point of view, it is also very important to understand that we have the myocardium, we have the endocardium, this is the cavity, and we have here the two layers of the serous pericardium. You have the serous pericardium, one layer here, the second layer, and this is the fibrous pericardium. Therefore, we have the myocardium, we have the endocardium, and here you can see that this is the visceral layer of the serous pericardium. This is the parietal layer of the serous pericardium. And this is in blue, this is the fibrous pericardium. Therefore, the pericardium, we have two components, the fibrous and the serous. And the serous pericardium, we have the visceral and parietal. And this is the pericardial cavity. The pericardial cavity in between the visceral and parietal layer, the pericardial cavity. And what's the name of the visceral layer? The name of this visceral layer is also the epicardium. Endo, myo, epicardium. And what is the epicardium? The visceral layer of the serous pericardium. Therefore, in this specimen, we have removed the parietal layer and the fibrous pericardium. And now we have the visceral layer of the fibrous pericardium. This is the epicardium. For this reason, we use the term epicardial view. Okay, this is crucial to understand what is the myocardium, and for cardiologists and for people that are in the beginning to understand the myocardium, is also crucial to understand that the myocardium have two components. One are the cardiomyocyte, and second is the interstitial space. And the interstitial space have one that is the cellular component and the extracellular matrix. Cardiomyocyte, interstitial space with the cellular component. And what are the cellular components? This is crucial because are in terms of number, the cellular components are the more important number in our heart. The name are the fibroblast and the myofibroblast. Therefore, the interstitial space are with two components, cellular and extracellular matrix, and cellular with fibroblast. And fibroblast mean collagen. This is crucial for cardiologists to understand how are the component of the wall of the heart. Take into account in your mind because this is very, very relevant. And the future of the cardiologist is sure in the imaging technique to understand how is the component in terms of a scar, in terms of fibrosis in our heart, in terms of fibrosis in the left atrium. Fibrosis mean arrhythmias. And fibrosis, to understand fibrosis is to understand the extracellular matrix, the interstitial space, the fibroblast, and the role of the collagen tissue in this interstitial space. Let's continue with the morphology of the heart from an epicardial point of view. Then, this is the epicardium, therefore, and with the epicardium, we can identify different reflections. And the main reflections and the main sinus is the transverse sinus of pericardium. And the transverse sinus of pericardium is in between the aorta and the right and the left atrium. And here, you know that here we have the Bachman bundle. Note in this specimen beautifully this artery. This artery arising from the circumflex artery. You can see that this is the circumflex artery. And arising from the circumflex artery here, this is the sinus nodal artery that in 20% of the case go to the synod node. This is superior vena cava, this is the right aged appendage, and this is the area of the synod node. And note this artery. This is therefore important, the AV nodal artery from the right coronary artery. This is the right coronary artery in this case. And note the posterior interventricular artery or the interventricular artery or the inferior interventricular artery. Okay, then with this epicardial view of the right atrium that you can see, note that we have superior, inferior vena cava, this area that correspond to the terminal groove, all this area correspond to the trabeculated area of the right atrium endocardially, and this trabeculated area endocardially, this is the so-called pectinating muscle. Let's go to the endocardial aspect of the right chambers. The endocardial aspect of the right chamber can be seen in this specimen. And note, just a second, note that we have the aorta here, and we have the pulmonary artery. Note the different orientation of the aorta and the pulmonary artery, crossing positions. And this is because the aorta is protruding here. If I introduce my finger here, I can see this area. The name of this area is the so-called supraventricular crest. Supraventricular crest. This is the pulmonary artery. What is the difference between the pulmonary valve, the aortic valve, and the tricuspid valve? If you go again to the short axis view, you see that here we have an annulus. But in the aorta and the pulmonary artery, we have the so-called virtual annulus. They are an independent attachment of each leaflet to the junctions. This is the aorta, this is the anterior, left and right. They are an independent attachment, as you can see here. Note the attachment of the pulmonary valve to the root of the pulmonary artery. And here you can see the main anatomic landmark of the right and the left ventricle. Just to summarize in one drawing to facilitate your understanding to the right atrium, note here that this is the superior vena cava, this is the inferior vena cava, this is the right atrial appendage, superior vena cava, inferior vena cava, and here we have the tricuspid valve, and here you can see the right ventricle. And note that this area endocardially corresponds to the terminal crest. This is the area of the terminal crest here. This is, note that this is the superior vena cava in this specimen, and here this is the area of epicardially of this, and we have removed all the pectinating muscle in the right atrium, and these are the pectinating muscle. Can you see the pectinating muscle anterior and posteriorly? And you can see, can you see this thicker muscle that correspond to the terminal crest endocardially? Therefore, in the right atrium, the terminal crest divide the smooth wallet right atrium and the trabeculated right atrium. Note that this is the area of the pectinating muscle. And let's go again to the drawing. Here you see this is the septal leaflet, the tricuspid valve, and we can identify the fossa ovalis. Fossa ovalis. And you are going to identify the orifice of the coronary sinus. And in this area of the orifice of the coronary sinus, in this area of close to the septal leaflet, you are going to have the area that corresponds to the AB bundle. AB bundle, that this is the compact AB node and the His bundle. This is the area that we use the term triangle of Koch. Let's go this to identify this in the specimen. Let's see in this specimen that this is the septal leaflet of the tricuspid valve. This is the inferior vena cava. This is the inferior vena cava. This is the superior vena cava. Note this valve, the name of this valve, this is the Eustachian valve. This is the Eustachian ridge. And this is the Tevesian valve. Note the Tevesian valve, that this is the valve of the orifice of the coronary sinus. This is the septal leaflet of the tricuspid valve. You can see the tendinous cord and the papillary muscle, and pectinating muscle here, and all this area in the base of the heart. If you go here, this is the base of the heart. Note my finger here. You can see that this is the coronary sinus. This is the grid, the coronary sinus here, and this is the grid, the middle cardiac vein. And note here that this is the right coronary artery here, in the junctions, let's go again here. Note that this is the right coronary artery. This is fibrofatty tissue that correspond to the fibrofatty tissue of the AB groove. Note the AB groove, the fibrofatty tissue, and you can see the attachment of the leaflet. Okay, then what are the anatomic landmarks in this right atrium? You can see that this is the smooth-walled right atrium, and this is the trabeculated right atrium. What is the junction between the trabeculated and the smoothed right atrium? The terminal crest, endocardially. And here you are going to see by transillumination, what is this? This is the fossa ovalis. This is the through interatrial septum. This is the only septum, because if I have punction from here and from here, I'm going to the left atrium. Of course, I'm going to the left atrium. But I am not going, look here, I am not going through the fossa ovalis. Therefore, I'm going out of the heart and inside the heart, and I can have perforations. Therefore, to identify the through fossa ovalis is crucial here for electrophysiologists that are using transeptal approach or interventional electrophysiology, interventional cardiology that are doing close of the left atrial appendage or atrial fibrillation ablation or the mitral valve treatment. And it is also very important to understand the anatomic relation of this fossa ovalis with the transverse sign of pericardium and with the aorta, because there a close anatomic relationship between these fossa ovalis and the transverse and the aorta and the inferior aspect. And this anatomic relation is also very crucial to understand, just to avoid complications during these interventions. This is the right coronary artery. You can see the right coronary artery, and you can see here the right coronary artery. Imagine that the right coronary artery is here. And this is the septal leaflet of the tricuspid valve, and this is the tricuspid annulus. And the right coronary artery from here to here surrounding the tricuspid annulus. And this is the coronary sinus. As if you go to the coronary sinus, note here, where is the coronary sinus? draining here. And the valve protecting this valve is the Tevesian valve. Therefore, Eustachian valve, Tevesian valve, Eustachian ridge, and note these regions, these quadrilateral regions. This quadrilateral region between the septal leaflet and the Eustachian valve, this is the so-called cavotricuspid isthmus. And the cavotricuspid isthmus is the base of the heart. And note the anatomic relation of the cavotricuspid isthmus with the circumflex artery. Note, with the right coronary artery. Here you can see the right coronary artery. I'm going to focus the cavotricuspid isthmus. Can you see the base of the cavotricuspid isthmus by transilluminations? All this quadrilateral area that I am showing is cavotricuspid isthmus and its anatomic relation with the right coronary artery. Therefore, this is the base of the heart. This is inferior. The cavotricuspid isthmus is the inferior aspect of the right atrium. And the cavotricuspid isthmus, and here intramyocardially, if you focus here, this is the Eustachian valve, the Eustachian ridge, and intramyocardially, this is the area that corresponds to the tendon of Todaro. And the tendon of Todaro, and posteriorly, the septal leaflet of the tricuspid valve, and the base, this is the area of the AB junctions. This is the triangle of Koch. And if I have a punction here, I'm going to the left atrium. Look, I'm going to the left atrium. This is the area that I show here in this drawing that corresponds to the atrioventricular septum, the area of the membranous septum, the area of the entrance of the central fibrous body, the entrance of the His bundle. If I go to this area, can you see by transilluminations the membranous septum? Note here the limits of the triangle of Koch. The central fibrous body, remember, this is this one in yellow. This is this one. This is orifice of the coronary sinus. This is the septal leaflet and the AV nodal. Then let's go here, the orifice of the coronary sinus, the septal leaflet, the area of the membranous septum. Here we have the compact AV node and the area of the His bundle. Therefore, what are the anatomic landmarks of the right atrium? The right atrium is probably the more complex anatomic regions in the heart, and we have two components: one a smooth-walled right atrium and the trabeculated right atrium. The trabeculated right atrium is the appendage, all the area of the appendage, and we have the terminal crest. And we have the terminal crest, the Eustachian valve and the Eustachian ridge, the Tevesian valve, the cavotricuspid isthmus, the triangle of Koch with the membranous septum, the area that corresponds to the compact AV node. And epicardially, we have the region of the sinus node. Note also here the Chiari network. Can you see the Chiari network that you can see during some imaging technique or even when you move the catheter inside? Note all these valves in this area of the inferior cavotricuspid isthmus. If we open the right atrium here, you can see in this specimen, note, for example, this heart, we have opened this heart, this is the apex, this is the right atrium, okay, this is the right ventricle, this is the area. And now let's open, and let's open. Look, this right atrium, and note all this area that correspond to the appendage. close, and this is the apex of the appendage. Can you see all this area? But all this area is trabeculated regions. If we analyze this trabeculation and we compare with the left atrium, this is much more trabeculated than the left atrium, because the left atrium, the only trabeculation belongs to the appendage and the narrow appendage. Note here, again, this is superior vena cava. Let's superior vena cava here, superior vena cava, and here inferior vena cava, and the appendage. I'm going to open and note this. What is this? This is the very big fossa ovalis, and this is the fossa ovalis. The fossa ovalis, the through interatrial septum. If I go to the left, you can see the left side aspect of the left atrium. This is the fossa ovalis, because all the area is not the through interatrial septum. Let's go again here and let's analyze all the area of the right atrium. You can see that this is the terminal crest. Note the terminal crest, the anterior and posterior pectinate muscle, and this is the vestibule of entrance to the tricuspid valve. We are going to see 4 components in the atriums. These 4 components in the atriums are: one is the venous component, 2 is the appendage, 3 is the ovifolds, fossa ovalis, and 4 is the vestibule. The vestibule of the mitral valve, the vestibule of the tricuspid valve, the fossa ovalis is the same, left atrium and right atrial appendage, and the venous component, intercaval venous component for the right atrium and interpulmonary venous component for the left atrium. Therefore, these 4 components are very important to be able to identify in the atrium, and this is the vestibule of entrance to the tricuspid valve. This is the vestibule, and we show that we have the vestibule to the tricuspid and to the mitral valve, and this is Eustachian valve and the Eustachian ridge, and you can see here the Tevesian valve. If you focus here, this is the Tevesian valve. Note that this is the pouch of the cavotricuspid isthmus. Remember that we are in the base of the heart, and this is the cavotricuspid isthmus, and here this is the vertex of the triangle of Koch. And if we focus in this part, you can see again the 2 components of the membranous septum. The his bundle is here, and the aorta is all this area. This is the aorta. The aorta protruding in the so-called supraventricular crest. Note that here the membranous septum is in close anatomic relation with the aorta. And remember that the membranous septum is in this area between the nome and the right, between the nome and the right. And the his bundle penetrates through this area, to arise from the left bundle branch. Therefore, the right atrium, the triangle of Koch, the cavotricuspid isthmus, the terminal crest, the Eustachian ridge, the Tevesian valve, the Eustachian valve, the anterior and posterior pectinate muscle are anatomic determinants that we need to understand. Let's go to these sections. This is the 4-chamber view. 4-chamber view. And note that this is the typical 4-chamber view for imaging or for people who identify the echocardiographic view, and note that this is the interventricular, the muscular interventricular septum, and this is the left ventricle, thicker and oval. The right ventricle is thinner and trabeculated. And note here the area of the coronary sinus. Let's identify here the coronary sinus. The coronary sinus here. Then, what is this? This is the area of the vertex of the triangle of Koch. Therefore, we have the muscular interventricular septum, and we have the membranous septum. Remember that this is the membranous septum. We are again in this area, but in fourth chamber. This is the membranous septum. Can you see that here, if you focus, we have, this is the attachment of the mitral valve. This is the mitral annulus, and this is the tricuspid annulus. Can you see an inferior attachment of the tricuspid annulus in relation with the mitral annulus? And what is this area? This area. This is this area. The atrioventricular septum. Can you see the atrioventricular septum? And if you focus the atrioventricular septum, this is fibrous tissue. And this is the area where the His bundle penetrate. Can you see in fourth chamber view that this is the right coronary artery and this is the circumflex artery. This is the AV groove, the fibrofatty tissue of the AV groove. Therefore, the septum of the heart, the muscular interventricular septum, the atrio and interventricular membranous septum, and the fossa ovalis. And here you can see the fossa ovalis, the through septum of the fossa ovalis. Here we can do transeptally. Here you see the fossa ovalis. And this is the through interatrial septum. Let's see in this specimen. What is very important to the term that we use, the term through interventricular septum. Let's see here. Left atrium, right atrium, tricuspid valve, mitral valve, superior and inferior. And this is the interatrial septum. If we go from here to here, from right here, of course, we go from the right to the left. And of course, we go from the right to the left. But can you see this? Fibrofatty tissue. Can you see this is fibrofatty tissue? This is out of the heart. Therefore, the only fossa ovalis is the through interatrial septum, is this one, because superior and inferior, this is not septum. This is an infall of the right and the left atrium, and inferiorly, the area of the coronary sinus, and disaster. If we go from here, yes, of course, we are going from the right to the left. But after this, we are going to have a tamponade and pericardial effusion because this is epicardium. Therefore, to understand what is the through interatrial septum is crucial because superiorly and inferiorly, this is fibrofatty tissue. You can see this area. This is fibrofatty tissue. Therefore, muscular interventricular septum, atrioventricular and interventricular membranous septum, and the through fossa ovalis. Then, let's go to the right ventricle. If we analyze the difference between the right and the left ventricle in this figure, note that we have this morphology of the ventricle. This is here we have pulmonary valve, and all this area here correspond to the aorta, and this is pulmonary valve. And when we compare this with this figure, here we have, sorry, we have the mitral-aortic continuity. They are not this area in red because the aorta is here. The aorta is protruding in between the pulmonary valve and the tricuspid valve. And we are going to use three areas. This is the outlet, this is the inlet, and this is the apical component. The outlet, inlet, and apical component. And here we have the outlet and inlet. And this is the apical. Therefore, there are continuity in the left ventricle, there are continuity, remember this figure, there are continuity between the inlet and the outlet. And in the right ventricle, there are not continuity because we have the aorta protruding in between the outlet and the inlet. We use the term, this outlet, for the right ventricular outflow tract, and we use the term also infundibulum or conus for the right ventricular outflow tract. However, for the left ventricular outflow, we can use the term left ventricular outflow tract or outlet, but never infundibulum or conus. Let's see again in this endocast. In this endocast, note that this is the right, this is the aorta, this is the superior vena cava, this is the inferior vena cava. Note the appendage, this is the vestibule, this is the terminal crest, and here we have the compatible node, and note that this is the outlet, this is the inlet, and this is the apical component. And note that in between the outlet and the inlet, we have the aorta. This is the aorta. And the aorta forming this area, that this is this area, that is the supraventricular crest. Therefore, infundibulum, can you see that this is an infundibulum? This is a conus. This is the right ventricular outflow tract, and right ventricular outflow tract, infundibulum or conus. And if you go to the left side, note to the left side, let's go to the left side. Note that this is the aorta, this is the appendage, this is the mitral valve, and their continuity between the aorta, between the outlet and the inlet, This is the mitral-aortic continuity. And they are not infundibulum or conus, they are just a left ventricular outflow tract. Can you see the difference with this triangular form of the right ventricle? Therefore, both ventricle shows the three component, inlet, outlet, and apical component. However, in the right ventricle, the outlet and the inlet are the aorta here, that this is the supraventricular crest, and this is the forming the so-called infundibulum or conus. And in the right ventricle, we have continuity in between the mitral and aortic valve. When we go to this epicardially, you can see why we use the term conus. This is the conus. This is the conus. This is the infundibulum. For these regions, these arteries that can we see here, this artery are also the conus artery. Can you see the conus artery? And the infundibulum that can be seen here, note the infundibulum or the conus. And can you see all this trabeculation of the right ventricle? And what are the main anatomic landmark in the right ventricle? ¿Cómo vamos de tiempo? Ok, ¿puedes quizás bajar un poco, poner eso? Just a second, because I have the sun shining in my room and we are going just to close. I don't know how is the weather now in your space, in your... Okay, and you can see here that if we go for the area this is the aorta, and note this is the ventricle, and this is the annulus, this is the orifice of the coronary sinus, this is the inferior cava vein. Okay, the right ventricle. The right ventricle, three components: inlet, outlet, apical component. The apical component, the outlet, we use the term infundibulum, right ventricle outflow tract or conus. And the inlet, this is the area of the three papillary muscle. And remember that we have septal, anterior, and inferior leaflet. And what are the main anatomic landmark? We have a trabecula here. The name of this trabecula is the septomarginal trabeculation, and this is in continuity with this, that this is the moderated band, and we have an infundibular attachment of the septomarginal trabeculation, and here we have the septoparietal trabeculations. These are the main anatomic landmark in the right ventricle: outlet, inlet, apical component, right ventricular outflow tract, conus, infundibulum. In the right ventricular outflow tract, we have the infundibular attachment of the septomarginal trabeculations, and we have the septoparietal trabeculation, and we have the supraventricular crest. The supraventricular crest is the aorta. And here we have, in this area, remember this is the orifice of the coronary sinus, this is the compact AV node, penetrating through this area, in close anatomic relationship with the aorta, in close anatomic relationship with the aorta. And in this area here, we are going to have this medial or septal papillary muscle. We have three papillary muscles, one inferior and one anterior. And remember that although we can use the term, if you focus the term here, papillary muscle, this is the medial, and this is the anterior and inferior, this is not just a simple papillary muscle. We have group of papillary muscle with different base, with different body, with different head. And we can just have a picture or drawing with one simple papillary muscle, but we have group of papillary muscle here, and with the tendinous cord connecting to the septal anterior and inferior from the septal, from the medial. This is the septum. Here is the septum because this is the left ventricle. You can see that this is the left ventricle. Look my finger. This is in the septum. Therefore, we have the septum. This is the so-called septomarginal trabeculation that we have removed just to visualize the anterior, the septal surface. And here, this is the septomarginal, and here we have removed the moderative band. We are going to see this in the different specimen, but we have removed the moderative band. And therefore, septoparietal trabeculation. Can you see the septoparietal trabeculation here? This is the septoparietal trabeculation. This one and this one. And this is the apical component, and with the apical trabeculation of the apical component of the right ventricle. And note in the drawing that here we have the apical component. Then, if you see in this specimen, again, the membranous septum, can you see that this is the aorta, and the right ventricle goes through this area, the right bundle branch goes from this area close to the medial or septal papillary muscle and to the septal marginal trabeculation through the moderative band. Therefore, the relevance of the conduction system here and the septomarginal trabeculation, anatomic relation with the right bundle branch through the moderative band, and the moderative band connect to the anterior papillary muscle, sometimes also through the right free wall, but mainly over the anterior papillary muscle. Again, component of the right ventricle, 3 component: inlet, outlet, apical component. Apical component trabeculated, as you have seen in this specimen. Look, all the trabeculation of the apical component. Superiorly, the right ventricular outflow tract, the infundibulum, the outlet, the conus, and here the inlet with the 3 leaflet, the septal, anterior and inferior, and the 3 papillary muscle that are also septal or medial, anterior and inferior papillary muscle. That we should use the term group of papillary muscle is much better to use this term. And also its anatomic relation with the right bundle branch. And what about the left bundle branch? We are going to see that the left bundle branch appear in the left ventricular outflow tract. And we are going to see in this area the left bundle branch in the membranous septum. The membranous septum between the known and the right coronary cusp. And this is also crucial to understand how is this anatomic relation of the membranous septum in the right and in the left. Please note that this is because they are a crossing position of the right ventricular outflow tract and the left ventricular outflow tract. Therefore, if we analyze that this is the comparative node, the comparative nodes go through the membranous septum, and the membranous septum we have this anatomic relationship in the aorta, and we have the right bundle branch and the left bundle branch. This is the area that is non-branching AB bundle and branching AB bundle. And this is like to be perpendicular. If you go and you see the compatible node, this is straight, and here we have the left bundle branch, perpendicular through the area that correspond to the left bundle branch. And the three branches of the left bundle branch that we are going to see in some specimen. Let's go through this right ventricle. Note that this is the pulmonary valve. This is let's see a simple way. Okay, again, let's open the right ventricle. Let's open the right ventricle, and look, my finger is in the aorta. Here is the aorta. Therefore, this is the supraventricular crest. This is this area. This is the supraventricular crest. And can you see the small septal papillary muscle? And note that this is the septal marginal trabeculations, and this is the moderative band. The moderative band that we have the section because this is in these positions. And note all this area here and here that correspond to the septoparietal trabeculation. Septoparietal trabeculation. And note how is the complexity of the papillary muscle. You can see the papillary muscle. This is not as simple of one papillary muscle. You see different body, different head, and you can see that the papillary muscle go to tendinous cord, to the anterior go to the septal, and to the anterior and inferior leaflet of the tricuspid valve with the tendinous cord. You see here the tendinous cord. Sometimes the tendinous cord go directly to the septum. If you go, this is beautifully, this is septal. Can you see here? This is not only, you see the septal, and now the tendinous cord that is not just through septal or medial papillary muscle. Note here in this specimen, here and here. This is very important because it's going to depend of the septal motility. And now here again, look the variability of the tendinous cord. This is very relevant for people who are working with the tricuspid valve, percutaneous implantation of device in the tricuspid valve. Of now, there are many interventional for cardiac structure that need to understand how is this complex variability of the tendinous cord. Look here and look here, and in this specimen, look the variability in this specimen. Here is more directly through the tendinous cord here, through this, can you see this septal medial papillary muscle? This is larger. In 20% of the cases, there are not the presence of this septal papillary muscle. You can see the septal inferior and anterior that has been removed. And the anterior, remember that this is in connection with the moderative band. Okay, the right bundle branch is here, intramyocardially located, in contrast with the left atrium, with the left ventricle. The left bundle branch is usually subendocardially located. Let's go now for a thoraxis here, that you are going to see beautifully how is the arrangement of the AB bundle. This is, remember again, let's go for the drawing. Here you see This is going to be the simulated short axis for echocardiography. Then you see that this is pulmonary artery, this is the tricuspid valve, this is the mitral valve. Note the narrow mouth that mark the junction between the venous component and the appendage. Remember the three components for both atrium, venous, appendage, fossa ovalis, and the vestibule. And the three components for the ventricle, inlet, outlet, and apical component. Then for the atrium, venous, appendage, fossa ovalis, and vestibule, note that the pectinating muscle are inside this narrow appendage. You see the appendage here. Look the appendage. The pectinating muscle are inside. Look the appendage in the right side. Large appendage, therefore more trabeculated right atrium than the left atrium, because the appendage is containing the pectinating muscle. And here you see the tricuspid valve annulus and the mitral valve. All this area is the vestibule, remember, the vestibule of entrance, the vestibule of entrance. And this is the vestibule of entrance to the tricuspid valve, the smooth vestibule of the mitral valve, and my finger is here in the aortic leaflet of the mitral valve. Note the aortic leaflet of the mitral valve. This is the aortic leaflet of the mitral valve. And note the mural leaflet, the difference with the mural leaflet here, that is larger, the mural leaflet, and the mitro-aortic continuity. If you see inferiorly, note that this is the left ventricle, thicker, 1 centimeter, and triangular, oval, and triangular. And if you see again here, oval and triangular, and note that this is the septomarginal trabeculation, and this is the septo-parietal trabeculations. This is the septo, remember, again, yes, here, remember, the septomarginal and septoparietal trabeculation, inferiorly, because this is the base and this is superior, okay? Then you see here one leaflet and leaflet and leaflet. This is septal. Let's go again here. You can see the septal leaflet. The septal leaflet usually is shorter and less mobility than the anterior and inferior. This is the less inside and with the less mobility for the tricuspid valve. And this is here, you want to see that this is larger, and here you see that this is larger. Therefore, septal, shorter, less mobility than this one, anterior and inferior. This is anterior and this is an inferior or posterior leaflet, 3 leaflet, and you see the 2 leaflet for the aortic leaflet and the mural leaflet. You see the mural leaflet of the mitral valve. Then, with this in mind, you can see here that this is the aorta and this is the pulmonary valve, and note the 3 leaflet of the pulmonary valve. 1, 2, and 3 leaflet of the pulmonary valve. And the aorta. Let's go just to see how is the anatomic relation between the septal leaflet and here. What is this? This is the coronary sinus. And if this is the coronary sinus and this is the septal leaflet, here we have the membranous septum. This is the triangle of Koch. And if we go here, you can see that this is the membranous septum from the right atrium. This is the area that corresponds to the His bundle. This is the vertex of the triangle of Koch. Note that you can see here the three limits of the triangle of Koch. This is the septal leaflet of the tricuspid valve, the vertex, the orifice of the coronary sinus, and here the His bundle is penetrating. Therefore, if I open this and I show my finger here and I open the left ventricular outflow tract, you can see that this is the left ventricular outflow tract. And note that by transillumination, you can see the area that corresponds to the interventricular membranous septum. And this area of the interventricular membranous septum, let's try to remember this area, sorry, left fibrous trigon, right fibrous trigon, and membranous septum. And now, if we go to this specimen, you can see, again, let's go. This is posterior, and this is right, and this is left. Remember that we have known that this is posterior, left, and right. Known that this is posterior, right, and left. Therefore, the membranous septum is in between the known and the right. And here, in this area, we have the left bundle branch with the three branches, superior, septal, and inferior branches. This is the area, and note here, what leaflet is this one? This is the aortic leaflet of the mitral valve. This is this leaflet. And this is the mitro-aortic continuity. The mitro-aortic continuity between the known and the left. Therefore, the mitro-aortic continuity here between the known and the left. This is the attachment of the aortic leaflet or anterior leaflet of the mitral valve. And this is the right fibrous trigon, and this is the left fibrous trigon. Remember, left, right, and mitro-aortic continuity. Therefore, in all this area, from the left to the right, we have the left, just a second, just to facilitate you the understanding. You have the left, you have the known that is posterior, and you have the right. And from left to right, you have left fibrous trigon, right fibrous trigon. The mitro-aortic continuity connecting both fibrons, and here the membranous septum in yellow, and by transillumination the membranous septum. The His bundle appear in this area, and the left bundle branch here we have with the three branches, superior, septal, and inferior. Remember that all this area here we have in the left side. If I have my finger here in the left side, look where I am, in the compact AV node, Therefore, this is very relevant, because for those people who are doing percutaneous implantation of the aortic valve, you have in the attachment of the leaflet, you have the area that corresponds to the compact AV node the penetrating AV bundle and the left bundle branch. Therefore, for these reasons, the risk of induced AV block during the TAVI implantation is very high in some device. For example, it's different in the Sapiens. Recently, with the Sapien decrease, but with the previous one, with the coral valve, the risk of implantation was very high. And this is because we need to understand how is the anatomic relationship between the AV bundle and the left ventricular outflow tract. Finally, let's go to the left atrium and the left ventricle. Here you can see, how is our time? Okay, in 20 minutes, let's see the left atrium. Here you see in this specimen that this is the superior vena cava, and this is the left atrium. And note that this is the right superior pulmonary vein. Here in this specimen we have an intermediate right pulmonary vein, 20% of normal variability with a common ending. For example, in this specimen, here you have a common ending, common trunk for the left pulmonary vein. This is right superior, right inferior. And in this case, for example, I have one specimen here. In this specimen, you have a common for the left pulmonary vein, right superior, right inferior. And in this case, you have an additional right intermediate pulmonary vein, an independent ending for the left. Note that we have the coronary sinus surrounding the mitral annulus, and you can see here the appendage, the narrow mouth. And what is this? This is the area that corresponds to the transverse sinus of pericardium. Remember that this is like this one. We have removed all this the aorta and the pulmonary valve in this specimen just to visualize all this area. Okay, this you see that here we have the area that corresponds to the tricuspid annulus, and this area corresponds to the mitral annulus. This is the transverse sinus of pericardium, and this is the Bachmann bundle. This is the Bachmann bundle, and note here the Bachmann bundle, and just to visualize the right atrium, you can see here the area that corresponds to the superior vena cava. Note the myocardial sleeve extending. You can increase the thumb. Okay, you can see here the myocardial sleeve extending over the superior vena cava. This is the inferior vena cava, and this is the terminal groove. Here the area of the sinus node, and note endocardially the pectinate muscle of the right atrium. This is the terminal crest area endocardially, and this is the area of the apex of the appendage. And if we go to the left atrium, you can see here that there are some myocardial area, that there is a non-uniform myocardial content of the left atrium. Note that this is the left superior, the left inferior, and this is not, I think this is not for this class, but here you can see the myocardial content of the left atrium. This is the so-called septopulmonary bundle. This is the myocardial content of the left atrium. This is the left superior and the right superior. And here you can see how is the myocardial arrangement of the left atrium. This is circumferential fibers and longitudinal fibers. If we go endocardially to the left atrium, you can see that the left atrium have, can you zoom? Look, the thinner, thicker, and thinner. And this is the area that corresponds to the left superior pulmonary vein and left inferior pulmonary vein, and this is the appendage. Note here the appendage. Okay, what is this? This is the main anatomic landmark that we need to understand endocardially in the left atrium, that this is the presence of this ridge. But this is a ridge or not? This is a ridge between the left superior, left inferior, and the appendage. But if you go and you see in this specimen, this is not a ridge. This is just a fold of the lateral wall of the left atrium. You can see that this is not an increase of tissue here. And if you see epicardially, this is the area, this is the appendage, and this is the area of the ridge. This is not a ridge. And this area of the ridge, this is the leftward extension of the Bachman bundle. The Bachman bundle go from superior, from the left atrial appendage, from the right atrial appendage, close to the sinonodal region, surrounding all this area, and go epicardially in the area of the ridge. And this is the area of the ridge, epicardially. Note the appendage. This is the area of the appendage that we use the term landing zone for the deployment of the device to close the left atrial appendage. There's variability in this landing zone, and this is the main lobe. Can you use different terminology, cactus, etc.? But I like to use the main lobe and the different lobes, 3 lobes, but this main lobe is crucial to understand because this is like the vestibule for the deployment of the device. All these area that correspond to the deployment of the device. To understand how is the non-uniform myocardial content also to the left atrium, the presence of this trabeculated area of the appendage, and you see the area in relation also with the circumflex artery, that is the artery surrounding the area that corresponds to the mitral annulus. Therefore, when we see the 4 components of the left atrium, we know that the more important component is the interpulmonary venous component. We have the appendage containing the trabeculation. We have the fossa ovale and the vestibule, all this area that correspond to the vestibule of the tricuspid of the mitral valve. Finally, let's go to the specimen to show the left ventricle. The left ventricle here have seen in this drawing, you can see like a longitudinal section of the left ventricle, and this is the anterior or superior or sternocostal papillary muscle. Remember that we use the term group of papillary muscle, and this is inferior or diaphragmatic papillary muscle. We have seen the anatomy of the left ventricular flux and dimetro aortic continuity, but just to finish with these sections. Just so in this, I think this is a beautiful specimen that you can see how is the venous component of the left atrium. The left atrium is mainly smooth, but not always. Here you see the fossa ovalis. If you analyze without transillumination, you can imagine that the fossa ovale is this one, but this is like a pocket. You see that this is like a pocket because in fact the fossa ovale is this one. Therefore, this is important just to different cases, just because may contain thrombus. Then this is the vestibule of entrance to the tricuspid, to the mitral valve. This is the annulus. This is the through annulus. Can you see the difference when I had my first drawing here during this morning? This one, aortic, and this is mural. You see that this is the aortic leaflet. And if I introduce my finger here, I'm going here to the aorta, okay? And here, you see, I'm going to the left atrium and to the, this is the left atrium, and here to the aorta. Therefore, this is the left ventricular outflow tract. And note that here we have the mural leaflet. This is the mural leaflet. Different attachment. This length is larger than the mural leaflet. Mural leaflet is shorter and this is larger. And here you see tendinous cord from the board, from this margin, and tendinous cord. And now, if I have a simulated positions, like this one simulated, this is sternocostal and this is inferior diaphragmatic. This is superior. It's not only anterior, it's mainly superior. And here you see that this is the superior papillary muscle and this is the inferior. This is not the so-called septal, because the septum is this one. You see my finger? This is the septum. And can you see this beautiful left atrium? And note that this, sorry, just a second. Okay. This is because Cabrera is very perfectionist. And here you see papillary muscle, the thicker left ventricle, and note here the group of papillary muscle. Is this one papillary muscle, yes or not? No. Are these group of papillary muscle? Yes. With different head, let's go here, with different head, different body, several body, and look the attachment of the papillary muscle inside the ventricle, the left free wall. And note how are the presence of this intermuscular connection in the papillary muscle. Then we should use the term superior group of papillary muscle and inferior group of papillary muscle, sternocostal, or if you want to use the term anterior, but from an attitudinal orientation, are not anterior, are superior. And the same for the inferior papillary muscle. Note here, the papillary muscle here, and note how is different head, different body, and how is this connection. Note beautifully in this specimen. And note tendinous cord from the inferior, from the anterior, and from the posterior leaflet or mural leaflet of the mitral valve. You see the tendinous cord, and this is also very relevant for those who are planning to do percutaneous treatment of the mitral valve. This complex anatomy of the papillary muscle, the tendinous cord in relation with the aortic and mural leaflet of the mitral valve is crucial, is spectacular to understand how is the complexity of the left ventricle. Look, this small trabeculation in the left ventricle, this small trabeculation in the left ventricle is thicker. For people usually in the books is the so-called trabeculated ventricle, the right ventricle, but don't forget that we have this left ventricle with this complexity for the superior. Look here in this area. How is the connection of this group in relation with the mural and aortic leaflet? Look, this papillary muscle with different head and with different tendinous core to the mural and the aortic, and not only to the margin, but also here you see this one, these are in the leaflet. Note here that the level of the insertion to the leaflet is different, not only in this border, but also in the surface of the leaflet. And this is the books, we use the term first, second, but this is not the moment to explain. Okay, then I think that it's time, if you want to have any comments, any question, if you need to see a different specimen. I think that we had been the opportunity to see beautiful specimen and to see different areas of the right and the left chambers. And let me show you one web page. You can use, you can use this. This is Cardiac Anatomy Atlas page. In this page, you can see, for example, 3D models that you have seen this specimen. Just a second, this necesita un poco más, ¿no? Okay, this is charging. You can see this specimen, okay? And you can increase and to move inside the specimen. And the same, you have different 3D models, but this is our true specimen. You have just seen this specimen today in my hands, and you can see the anatomy, you can see the different aspects. Okay, I recommend you this page, Cardiac Anatomy Atlas, and you can see that in my Twitter, the link also. Okay. I'm open for your suggestion, for your comment, for any questions. Thank you for your attention, first of all.
Thank you very much. Can you hear us?
Yes, perfectly.
Yes. So as always, it was beautiful, and it's never the same. So it's quite pleasant to repeat your presentation, because every year it's different. The specimens are different, and the way you present it are different. Of course, what is inside is also the truth and correct, but it's very various. So do you have any comments, any questions for those who are maybe interested about interventional cardiology? So I think you understood our heart is a very dangerous area, and you have to be very cautious before putting things in it, inflating balloons, trying to go from one cavity to the other. Or you have or maybe to metabolize all the information you had today. And I thank you, Jose, for the link for your Cardiac Anatomical Atlas. I think it will have a lot of success. Any questions, comments? Yes.
Yeah. Thanks a lot for the talk. It was super interesting. I've seen it, I think, a few years ago, but I'm still discovering a lot of things. I have two questions. One about the east bundle and the left bundle branch. You told us that the left bundle branch is divided into three bundles. I never heard about it, but we have a way to image it. I think it's basically what we're seeing. Could you give me a bit additional information about the three sub bundle?
Yes, you know, first of all, You say that every time you see new themes. Remember that Leonardo da Vinci and Vesalio was working 500 years ago, and every time that I see new, we see new different structures because it depends the eyes that you look the structure. Okay, what about the three bundle of the left or three subdivision of the left bundle branch? There are some controversies in this. There the group there a group in Argentina that always have the draw of two branches, of two subdivisions. The septal is not always recognized for some group in the electrophysiology or in the cardiologist world. We have many dissection from histological point of view, and we have seen that the main trunk of the left bundle branch that appear in between the right and no coronary cusp of the aortic root, between the right and the non. This is this area of the membranous septum, and here you have the penetrating heavy bundle, and you have the left superior subdivision very close to the right coronary cusp. This is usually very reproducible. This is usually large, horizontal, and thinner. And usually it is very close to the right coronary cusp. And you have the septal and you have the inferior. The superior go to the close to the left, to the superior papillary muscle or superior group of papillary muscle. And the inferior usually go to the inferior group of papillary muscle. What about the septal? Septal sometimes is very polygonal. The variability is mainly in the septal branch of the left bundle branch. Usually the septal is in connection, sometimes it's like a trunk arising from the main trunk of the left bundle branch. Sometimes it's with different branches to the right and to the left. Sometimes it's very polygonal. And in the web page, you can see one presentation that I did for the Asian Pacific Hereditary Society recently. And you can see some reference to the Molly's. There are several drawings from the group of James originally. That the issue is to understand that we have a main trunk with a variable length and with a variable thickness. This main trunk arises from the area, not from the membranous septum, is more closer to the right coronary cusp, because from the membranous septum we have the penetrating heavy bundle. You have the main trunk with the variable length, variable thickness. You have a very reproducible, long, thinner, and horizontal superior. You have more reproducible inferior subdivision from the left bundle branch, and for the septal subdivision, there are a lot of variability. It's like a fingerprint for any heart. You have some connection from the left to the right, some individually, but no doubt that we can consider very correctly from histological point of view that the left bundle branch has three subdivisions: superior, septum, and inferior.
Thank you. Other questions? It was a very interesting point, but a lot of variability, so it's difficult to predict.
In case I have a second
even the
one.
people who are performing, left bundle branch patients,
Yes.
they know that many times they go in the distance from the septum through the left endocardial aspect in the area that corresponds to the septal
So,
area.
which is the case in our hospital where Mark Strick performs a lot of stimulation on left branch directly.
Yeah.
Other questions? Yes, one more.
If someone,
I don't know. Did you have a question to ask? Yeah.
would it be possible to look again at really briefly at the specimen where you mimic let's say a short axis view or the echographic view at the base of the sample?
Yeah.
If-
Your
You mean
your
you want to see the short axis, and what do you want?
short axis of the base.
Yeah.
I guess with the mitral annulus and the artery and the pulmonary artery.
I think so.
From
it's
the base.
possible.
Let's see the specimen. Just a second. Okay. You mean you want to see
Yes.
the?
Yes, this one specifically. So, I'm involved in a, let's say, a project about the study of the fiber architecture in samples. So yeah, I have a question. So it's regarding the intraventricular septum. So I would like to know if the external part of the intraventricular septum, I mean the RV part, where you see, let's say, a less compact myocardium, maybe close to the SMT, for instance. Can you
I am not sure if I am able to understand what are
So
you.
he's talking about the right part of the intraventricular septum. Am I correct? Yeah. The right part of the interventricular septum. So we can see very nicely the septum here, with the right on the left of the image and the left on the right of the image. Yes.
And so on the so it's, I mean, in the muscular part, I would like to know if yes, the part you're pointing at is part of the septum or is considered as out of the septum.
This is
Okay, I know. Okay. Well, you see that this is from this point, this is the septum, okay, but this is the area, for example, that we use the term inferoseptal recess, and this is the area that this is not the through area that we have shown here. The through area that correspond to the septum, no? This area of the septum. Well, this is the septum, okay? And you mean this is an area of the septum, yes or not? Not. This is the area that correspond to the inferoseptal recess, and this is the area between the aortic and the mitral, and but this is not the septum. The area that you can see here. This is an interesting question I see now, because you mean with this projection, your question is how is the extension of the septum in this point? No? This is more or less your questions.
Yes. So, for instance, is the parietal trabeculations is included in the septum? When you look from the RV side, for instance.
Yeah. For example, let me just a second.
And in your sample, you have a slight difference of contrast in the tissue. So it's really specific, but we're working on these topics.
Look here. Okay. This is the septal area of the ventricle. Okay.
Yeah.
This is the septum. Okay. Then your question is if this trabeculation belong or not belong to the muscular interventricular septum. This is a very interesting question because in fact it's the same like the papillary muscle. This is you see the free wall, and you can see the papillary muscle connecting through the left free wall. Okay.
Yeah.
This is interesting question. I am not sure. I think that this septal area and extraventilation of the muscular interventricular septum, true. But I never have been thinking about if this is should consider septum or this trabeculation muscular septum or not. Probably yes. But this is, you can email me to give me feedback and we can discuss this.
Okay, thanks a lot.
Thank you. Other questions, comments? Well, thank you very much again. I saw everybody here were taking notes and very interesting by your talk and always comparing your specimens with umbilical branches they can find on Google at the same time. It's really beautiful. Thank you again.
Thank you. Thank you. Have a good day. And thank you again, my friend, for your invitation. You know that I love cardiac anatomy and to share my knowledge.
Yes, we can see it.
Thank
you very much. And I see you next year?
Of course.
Good. Have a nice day. Bye-bye.
I will prevent my myocardial infarction just to be next year.
Okay. Have a nice day. Bye.
Thank you. Thank you.